This week on the BackTable Podcast.
Culture eats strategy for breakfast. You can have everything planned out perfectly and everything set up in the room. You could have everything you're going to do for that case. If you're treating people poorly and you're yelling or whatever, like, doesn't matter what plan you had. That day is just not going to go all that well. And the opposite is true. You can do everything, you can be surprised by something, but when the team steps in and figures out how to solve the problem with you, culture got you through that more than anything else, or as part of it at least. I think, obviously you got to know your anatomy and know how to do surgery and be prepared. But sometimes this job surprises you, and having a team who's willing to jump in and help out without having to be told will be the difference between something we figure out and something we miss.
Hello, everyone, and welcome to the BackTable OBGYN Podcast, your source for all things obstetrics and gynecology. You can find all previous episodes of our podcast on Spotify, Apple Podcasts, and on BackTable.com.
This is Mark Hoffman, and we're here for another episode of BackTable OBGYN. And today I've got with me my co-pilot, Amy Park. Amy, how are you?
Good. How are you, Mark? I'm
good. As everyone knows, section head of Urogyn, or female pelvic medicine and reconstructive surgery. Are you guys switching to calling it Urogyn now?
It's actually, we are, as of next year, it's going to be officially urogynecology and reconstructive pelvic surgery. So ERPS instead of FRS.
And we can still just call it Urogyn, right?
Yeah.
Okay, good. And MIGS is going to change names too, I think, right? Complex gynecologic surgery or something, maybe? I don't know.
I thought the surgery was going to be different. Like it was complex gynecology instead of complex gynecologic surgery.
Right,
I wasn't sure.
Because we're taking care of medically managing things too. But I don't know, whatever. I'll keep doing the same stuff. You can call it what you want. But as always, great to see you.
Great to see you.
Oh, well, thanks. And we're going to talk about complications today, which I think we've all had more than our share than we like to. But I think it's an important thing to talk about, and not just terrible things that have happened, but more importantly, how we deal with them and ways not just we as individuals, but how systems can manage it. When we say complications, what does that mean to you?
Oh my gosh, this is such an existential question. Seriously. So as I go on in my career, it becomes more and more unclear. Like before, I used to think, oh, if I have a visceral injury that it was unanticipated, it's one thing if you're planning on excising like bladder endo and you're going in, or like a nodule in the ureter. But if you have a bowel or bladder injury that you don't anticipate, is that that's a complication? Yes. However, as I've gone on in life and having gone through a lot of complications, first of all, you can never get your complication rate to zero. And I know that's something one of my mentors, Mark Walters, said, and it tortured him. And it never got any easier to deal with the complications. For me, the complication is, yes, it's an unanticipated thing, but where I really draw the line is like, if I catch it during the index surgery, I can deal with it. But the complication that's diagnosed down the road, to me, that's so much more consequential, having to diagnose it or you miss it somehow. So intra-op complication, yes, it's bad. The, bleeding, visceral injury, I don't know, taking out something that you didn't mean to take out, like taking out the wrong side ovary or something. I mean, these are all sort of big consequential things. But I think that as I go along farther in my career, I'm like, what's even more important is how you handle it.
No, I think that's true. I agree. There's so much that goes into this question, but I think that is something that takes time to understand that. And I think it's something that as you mature, starting off as a medical student and seeing bad things happen, you're an observer. Like you have a window into it. As a resident, you feel very responsible for things that happen, even though ultimately, like the attending is the one who's most of the time is the one ultimately responsible. But when you first start your career as an attending, I don't know about you, but I felt so much pressure to be perfect, especially because I was doing something that first MIGS surgeon at my institution. I just felt like everybody was looking at every single thing I did. This idea that if anything that I did, if there's any complications, it's sort of it didn't just reflect my abilities as a person. It reflected my choice to do this particular specialty. And I was trying to show everybody that I felt what I was doing was important and that I could provide something for patients in my community. it was a lot of weight. It felt very, very heavy, and every little thing that happened, it would like destroy me in a way that was like not sustainable, I guess. That was something that I've had to like learn about in ways that I think have allowed me to be better at what I do, but also how to teach that better. But I think it's something I've paid attention to for a long time as a student, as a resident. I think I felt very responsible for any patient interaction. And if a case didn't go well, I would blame myself for everything. I don't know. Some people just seem to like not care as much. Not that they didn't care. They seem to bounce back a little faster, maybe.
Well, I think that you bring up these good points. And yes, these complications are devastating. And I conceive of it like grief, like the death of a loved one. I don't know if you've seen that infographic where you have the grief and then it's a circle and then there's another circle surrounding it. And then it's like the grief is taking up most of the circle. But then as time goes on, the grief stays the same size, but then the surrounding circle, which is you, gets bigger and you can contextualize it and deal with it better. I think that complications are very much like a form of grief when you're dealing with it and having to psychologically deal with them. And I think some of the things that I have had to grapple with is not letting it ruin my life for 6 months. Sometimes it's your first case and then you have to like get back right on the saddle. I mean, I've wanted to quit. I've wanted to like just cry every night. I'm sure I did earlier in my career. But I think the thing that I really encourage people to do is just be super analytical about how you can do better and just try and recognize the circumstances that led to it. Like somebody's had a uterine artery embolization, that the anatomy is altered. Like I've had ureters come down around wherever just because it's just also patients who've had gastric bypass and have lost over 100 pounds. I think they have just stretched out anatomy. There's cervical elongation, overhanging bladders. These are all entities that I like recognize because they just are, to me, risk factors. I mean, there's risk factors like prior C-section or whatever. Those are things that I can sort of are known quantities in the literature, but there's just other things where I'm like, okay, this is where I got into trouble before. And then the other thing that I will say is diagnosing and dealing with the complication and doing the appropriate diagnostic workup and then management is of utmost and paramount importance, and how you interact with the patient and the patient's family. I mean, I tell the trainees this all the time. So, we have a complication. So what? Like, you have to like be all over it. Like, don't blow off the patient. That's what the patient doesn't like. Not listening to their concerns, not taking them seriously. Like, it's better to just bring somebody in post-op and see them for 15 minutes and just reassure them that everything looks okay, or get the CT scan and just make sure that their nausea is just related to narcotics or whatever it is, as opposed to something serious, because that's when people get really angry.
If you can't reassure yourself over the phone, you got to see them, like, period. I am so fast to get them into my office or to the ER. I don't care what metrics show. If I can bring them into the ER and they're fine, okay, good. But those ones that you missed, I agree. I think the two biggest things for me with complications, not even this surgical part, which we'll get into, but like sort of preparing your patient for a complication, I guess. So like the consent process, how you counsel them pre-op. I think patients understand complications. I think they don't like surprises. So if I'm doing a big stage 4 endo case and when they've seen colorectal and they've gotten a bowel prep and like it looks like it's bad and there's a possible ostomy and we talk about it, like probably not going to happen, very unlikely, but like it might. That's different than like, this is going to be smooth sailing. Everything's going to be great. And then they wake up with a bowel resection. Like setting reasonable expectations going in, and not unreasonably low, but like reasonable, like here's all the things. And when they're making their decision for surgery, these are the things. But I think what you've said is the most important thing, which is when, not if, but when complications happen, how do you deal with it? My patients, they get my cell number when there's a complication. Like they get to call me whenever they want. The family gets to call me. There's no one's calling a nurse. No one's talking to, like, no one's going to have a hard time getting a hold of me. Whatever you need. Like, you stay as long as you want. Once happens, twice is on me if there's a second complication. Because the chance of that second complication is so much higher after the first. You have to be, like, on high alert all the time.
I agree with that. I think that's when you really have to give out your cell phone or your email or whatever it is. And patients really don't abuse that. They really just reach out when they need you. And the last thing you need is some mishandling from like the triage system, one of the residents or the nurses or whatever, who I love, and they're part of your, like, a very, very well-tuned machine, but like things happen and
they weren't in the case. They didn't see it. It's not their fault.
Yeah, and they need to, the patients need to see you right away or talk to you right away, and you can triage it yourself and take responsibility for everything. I absolutely 100% agree with that. And then see them as much as they need to be seen in person, or call them, or whatever it is. And I think that's just like handling it and just also appreciating where they're coming from. And you said a really good point, which one of my former partners, Andy Sokol, said this, and I totally believe it, which is you want to under-promise and over-deliver, which I definitely agree with. Like when I am talking about reconstructive pelvic surgery, I tell people, like, I'm like, this probably lasts 10 to 15 years, just like if you had an ACL tear or a knee replacement or a facelift, it just doesn't last forever. I mean, what lasts forever is extirpative surgery, like a hysterectomy will cure your bleeding.
I tell patients, I don't get to say 100% very often, but if I take out your uterus, 100% of the time, you will not have uterine bleeding after this surgery. And that's the one time I get to say it.
Yeah, exactly. But like, also, you're right. The expectations are completely different for a benign surgery as opposed to cancer. Cancer surgery, the metric is completely different, and people are way more tolerant of complications. Just like for obstetrics, it's way more higher bar. If you want to talk about with the definition of complications for obstetrics, I mean, you could just get into like a rabbit hole of like I don't know. There's like so many things going on there of what people are wanting in the process and what outcome you're looking at. And it's completely, you can do everything right, and it's unanticipated outcomes.
The one part about OB I do not miss is the fact that there's, it's 99%, 98% good outcomes or whatever, but the ones that are bad are so bad, and you can do everything right, and it just sometimes bad things happen, and it's just devastating because it's like the one reason you go to a hospital that's not like pathology, right? It's a normal thing. You're going to the hospital.
Joyous.
Everybody else in the hospital is there because they don't want to be there. It's like the one group of people who are like, oh no, I'm here because I'm excited about expanding my family. And then when something bad happens, it is just, that's a whole other episode, because that to me was the heaviest of the heavy things in what we did. But
I agree. We were just talking about this with the nurses today in clinic, like dealing with the IUFDs, the intrauterine fetal demise. That's the number one worst thing in our field by far. Like cancer and all that other stuff is like distant second. The wailing, the grief, the devastation, and then having to like be really happy for the next patient that came along. It was terrible.
Oh, the dichotomy. I think about that. Like part of me like wants to write a book about it, but like you could like be delivering an IUFD, and then like 2 seconds later you're pulled into a room with like balloons and like, hey, guess what? And they have no idea. They have no idea what you just saw and went through. Though it's different, I do think there is some of that grief, like you said. I mean, I was thinking trauma, but I do think there's a grief. And I definitely remember the patients more than the complications in that sense. Like I remember the cases very well, but like when I've had complications, when I've had cases that didn't go the way I wanted to, God, just like talking to their families. And the crazy part is a lot of those patients are the ones who've referred me their friends and family afterwards. I'm just like, and I'm just thinking so poorly of myself, but they understood. But how I handled the complication was what they wanted to see, I guess. I don't know. I'm still baffled by that entire thing. But I mean, sometimes just cases are tough and bad things happen. But I think the initial part of it for me is the isolating, the lonely, the very like Mark-centered version of how to deal with it. And I think I should give my fellowship grand rounds on failure, because it didn't seem sustainable to do that to yourself all the time. And I saw people who were burned out, people who had that myth of perfectibility, and that was from a paper I'd read when I gave that talk. This idea that anything less than perfect is a failure. It helped me a lot. My therapy, in a sense, with having complications or having outcomes that were not the way I wanted it, was to figure out why it happened, to dive deep into how it happened, whether it was, learning anatomy you do when you're younger, but, whether it's a systems error, how did this thing happen? How did we let it happen? And you grieve briefly, but then you have to move on some way. And the way for me to do that was to understand the why, or the how of how this happened, so I can make that next patient's experience safer and better, and how we sort of like deal with it. I mean, everybody deals with these complications differently, but that was the way I did it. I would give myself a time to feel bad, but then I'll have to do something about it to make the next patient a little safer, I guess.
Well, that's what I'm saying about I alluded to this earlier, is just being analytic about where or how this happened and what contributed to this, or what was a move, or how you handled the tissue, or whatever it is, like the entity, or maybe a different approach, do it laparoscopically instead of vaginally next time, or whatever it is, or do a combo case with somebody else. I mean, all of those things are things to like really, really do a deep dive and analyze. And then that whole adage of like judgment comes from experience comes from making mistakes. I always try and tell the trainees, like, this is where you can get into trouble. Like, I want you to know this so that you learn and you know it, so you don't have to learn it the hard way. So that's like the thing with M&M too. And I always think these punitive type M&Ms are completely counterproductive in my mind. I mean, this is like, how can we do better? And talking about a robust quality and safety culture, I think you have to strike a balance between learning how to do better, but it doesn't sound like it's blameful or punitive or...
But that's what M&M historically was. It was,
yeah,
let's put it out there and get better, but as doctors love to be mean about stuff. And so I think that's a lot of what it became. And some of the M&Ms I saw as a med student were just like...
they're brutal.
Bananas. Like people storming out and screaming at each other in tears. And it was just like, what? Who's learning here? And ultimately what you realize is like, you just want to have like the third or fourth worst complication of the week, right? As long as somebody had a worse complication than you, then everything's fine, because they're going to yell at that person, not you, or they're going to make that person feel like an idiot, not you. And like, what a useless activity when we could all be learning from all of our mistakes. And so one of the things that I did when I first came to Kentucky after my fellowship and after I'd given that talk was I would raise my hand and be like, hey, I had this complication. Can we talk about it? People would look at me like I was crazy. Like, why are you bringing this attention onto yourself? And I was like, number one, because I want to get better. But number two, because I want to show our students and residents, this is how you get better. We all make mistakes. No one's perfect. The idea that you're perfect is a myth. It's a lie. It's a great way to make somebody go crazy thinking that they're a failure. When part of my talk, I talk about my brother, who's a comedian and an actor, and he spent a year when I was in residency trying to get jobs. I think he auditioned like every day and we got like 1 or 2 jobs, right? So his success was 1%. Our failure rate is like, 1%. And that's the part we lose sleep about. Like, my brother should have his PhD in failure. Like, he's so good at it. You just got to get back in there and do it. And that was something I was like, okay, I have to figure out how to get good at failing, even though we do it rarely. And so it's something I actively like worked on. Like, okay, have a failure, like spend a lot of time on that rare thing and really try to get good at screwing up. Does that make sense?
Well, there's 2 programs that I know of, and I'm sure there's more, or not trying to address these issues, bridge the gap, so to speak. But like, my friend is at Beth Israel in Boston, and then Angela Chowdhury, her peer-to-peer coaching program. A lot of it has to do with just peer support, trying to get people through these complications, because you know what? Like I said, I mean, I'm not the only one who wanted to quit when these things happen. And especially when there's like a legal component to it, it can be really, really challenging. But then for brutal M&M, it's just like rubbing salt into the wound. Like, we need another excuse to feel bad about ourselves and like second guess all the moves. So I think those programs seem to have been pretty helpful. I think it's hard to scale up, and you have to have people who are willing to listen, which is tough. You have to have a true culture of support in the department to talk through these things in the division. So I think there's stuff out there now. At least there's American Medical Association, all these other societies have talked about the second victim, how the physician also is victimized by bad things like legal cases and complications, etc. And there was this whole code of silence that the lawyers would tell us not to talk about the case. And then, seeing these things come out, like saying, hey, it is really hard to deal with this without talking to somebody. So yes, it's okay to reach out to your peers and get some support, because it's like a very lonely road. And like you're saying, in terms of saying, hey, I've had this complication before. I mean, like, everybody's had these complications before. My friend was talking about this is in the business world. He was a small business owner. He just got acquired by this big firm. But what really helped him in terms of support and scaling up and feeling better is that he was in the company of all these other small business owners in Cleveland. And he was like, oh, I'm not the only one in the world who like has made these mistakes. I've made all these mistakes, and listening to all these other business owners who've walked down the same path and realizing that I'm not a failure. It's just like, this is what we are all going through. Because he was like the HR department. He was legal. He was everything. He's the manager. He's negotiating the contracts. I mean, he was everything. So it was just really heavy for him. And then knowing that there were other people out there who were going through the same thing just opened his eyes and made him feel so much better. So I think there's just so much solidarity and support that we can offer to each other. And the culture of medicine has changed and surgery has changed around this quite a bit, because it was very blameful and it was very superior previously, which I hope is continuing to change.
I think there are, and I think it's changing. I don't know that I can say I think it's changed. I think that it's more accepted to talk about those things. But I mean, you talk about Mark Walters a lot. I think about Ernst Lingel, who is the chair at the University of Chicago, who's one of my sort of surgical mentors. That's the voice in my head, when I'm operating, the person who sort of like the first person to really teach me surgery. He's German, so it's an extra scary voice. But he was very open about complications. He was very open about things that he had done that didn't go well. And I thought of him as like perfect. I just thought, I don't put a lot of people on medical pedestals, but like he was incredible in the to operate with. I mean, taught me so much. But he's also one to like just always talk about, I had a thing here once, like you said, like would teach you on the way. And there's other surgeons though who, like if you like clip a tiny vessel, they like freak out and yell at you. And then you see them like do the same thing 5 minutes later. And it's like, everyone makes mistakes, but you're either teaching and being honest or you're lying to yourself and everybody else. And I think there are still people out there who live and think that way. But I think the moral of the story is the point of this is to find those people who will help you get better without judgment, who will share their mistakes with you to allow you to make those mistakes less frequently. And anybody else who works differently is just someone you might want to spend less time with. But I think we've both been lucky to have mentors in a lot of places. I've had some situations where I haven't had as much around me directly, just based on the way the hospitals are set up and things. So I've been sort of alone in that sense sometimes too. That's very, very isolating in that time. And that was something that Arnie Advincula told me before I came to Kentucky. It was like, don't be a cowboy. Like, be smart. Don't get it over your head. You got to put patient safety first, even though you're trying to do new exciting things. That was some of the best advice I ever got, because to me, confidence comes with after a long time of doing this, not the other way around. People who just run in confident are just lying to themselves. And so having a large N, that's the other thing I wanted to talk about, is having that big N underneath a big denominator of cases that then if you have your first complication in your second case, that's a pretty bad percentage. If you have a long number of years and few complications, it allows you to feel a little bit more at ease. I don't know, just being conservative without being a wuss about it. I guess that's another big question, like, when to push the boundaries and when to lay back, because there is danger in doing too little sometimes.
Yeah, I agree. I think that coming here to the clinic after being in practice for 11 years, I would say it's interesting because people didn't know what I was like and what my surgical skill sets were, and I definitely had to prove myself again. I was in a higher position here as section head. But fortunately, I'd already made like all these, I've kind of like went through all this growth, like early and mid-career growth. And I'm still growing, don't get me wrong, but like I'd already had like a pretty big number of cases behind me. So that was to my advantage actually when I came here, because I'd already done a lot of cases and been through the ringer several times. Number one. Number two is, I think, establishing confidence and your reputation in a new place is just really tough. And I think I got that same advice too. Don't be a cowboy. Like your first year, you're really trying to like establish a reputation. I mean, there's this book called The First 90 Days, and a lot of the reputation is set from when you first get there. I mean, obviously you have like, it's not just the first 3 months, it's probably the first year or so, but a lot of these same principles apply. And then just the other thing that I will say is there's all this data showing that if you don't have a good culture in the OR and the surgeon sets a tone, like there's higher complications. So, and I think it was a JAMA surgery article that was published in the last year or so, that people in the team don't feel like they can speak up, like the anesthesiologists, the trainees, the nurses, And it just makes sense. So for those people out there who are still yelling and making people scared in the operating room, it's detrimental to people speaking up. Like, I wish I could say I have eyes everywhere, but sometimes you just are so focused on what you're doing and you need to have somebody else point out, like, something else is going on. And that is of paramount importance. So I really encourage everyone to have here we have a lot of education around it, but the strong safety culture with just and fair culture, then you just need to promote all the principles, speaking up without retribution, without belittlement. I mean, these sound basic, but it still needs to be said, you know?
It's probably basic in other industries, but it is without question something that I have led with. I learned that along the way in fellowship. I think we as surgeons, we as doctors, you lead from, forget whatever titles you have. You're a leader. Tell that to all of our trainees, whether it's staff in the clinic looking up to you or looking at you for answers. When you walk in the OR, you set that tone, period. Do you do a roll call with your timeouts?
I pretty much know the staff at my...
But like students and stuff. So that's every time out, we stop and we'll introduce everybody by first name, and like the striker rep or whoever, the nursing students in the corner. I'm like, okay, and your name and what's your role? And everybody gets introduced. And all of a sudden they feel like they're part of the team in a way that I think they're normally just kind of ignored because they're not kind of like the ones right in the middle of it, and they feel that way. And if you include them and talk to them and use their names, all of a sudden they feel more likely to speak up. And that was that study. It was like after a couple of airlines crashed, I think it was Korean Airlines, they realized that the captains were warned by the co-captains of the problem and kind of blew it off. And so they started using first names because you're more likely to speak up if you use a first name. It's less hierarchical. And so I want my student to be like, hey, there's something wrong here, and speak up. Like, I don't know everything. Because I think a lot of us are afraid to say something like, well, I would say something, but I don't want to insult them. Because I'm, assuming if I bring it up, I'm saying to the whole room that I think the surgeon doesn't know what they're doing. Whereas I want the opposite. I want everybody in the room to feel comfortable speaking up. And I could say, and the way to encourage that is when someone says something that you already know, you can say, you know what, thanks for saying that. I did know that, but please always say stuff like that so we're all working together. And they're not afraid to speak up the next time, because it's how you respond when someone says something is how they will act the next time, right? It's like, it's super basic stuff, but it's so true. You yell at them, guess what? I'm just not going to say anything ever again.
The other thing I will say that is, I have to say has worked in my favor is when you and I were coming up. I mean, I'm a little older than you, but definitely when I was a resident and fellow, the more you were a divo or diva and you were yelling and whatever, people were scared of you, and they would just assign good nurses to your rooms. No, the good nurses, so that they wouldn't have to like listen to the complaining. But now that stuff like doesn't fly anymore, and the good nurses will request you. I
was leaving the OR, this is like last year, I think, at some point, and I was working with a nurse who I knew but hadn't been in my OR much. I was like, hey, that was fun. Thanks for a good day. And she's like, your room was like Fort Knox. I was like, what do you mean? She's like, Jenna, who's my scrub tech that I've been with for the last decade, we're just like best buds. Like, Jenna's got this room on lockdown. Like, she like always works with you. I was like, oh, because we have fun, we just like, we're buddies. We have a lot of trouble just, most of the places in this country, we have a lot of travelers, we have great nurses, but they're just, if you're not around a lot and not familiar, it's a little more challenging. And I sort of realized at that point, like, oh, I have the same nurse because I'm nice, not because I'm the best surgeon or anything else, but because we have a good day in the OR. And the CRNAs will tell me when they come in, like, everyone told me I'm going to have a good day today because we're in the OR doing cases, because they know we're going to try our best and we're going to do good work and we're going to be kind to one another. It's not easy stuff we're doing, but we're going to be kind. And at the end of the day, we're all going to feel like, okay, we kind of did our best today. And that's all anybody wants. And why people think yelling at people gets the job done in a better way, to me, is crazy. I mean, I told you, we talked about the no asshole rule before, but just creating a culture of being nice to each other, and outcomes are better. Like you said, people will have better outcomes. Their patients get better care when the staff are nice to each other and we have a nice culture in the OR. It's not rocket science. It's not crazy.
Well, the thing is, it's like I hear from my Walter Reed colleagues that they're philosophically want to rotate the team. So like you could be ENT one day, and then you could be urology, and then you could be gynecology. or neurosurgery, and they're completely different instruments. And when you have people who don't know your instrumentation, it's like very, very challenging. So having someone who works with you all the time, who knows exactly what your steps are, how you do it, that's just priceless. Like where you find the laparoscopic clips in your time of need, it's like amazing.
People aren't sitting on the launch pad at NASA like, oh, hey, nice to meet you. Who are you? And like, what? Oh, so are you're going to be the pilot? Okay, I'll be the captain. Like they've been training together for years, right? Like it's safety.
It's so important. So I highly acknowledge that I would not be here and avoiding complications without like an amazing team. And I have people who work with me pretty regularly. And we're really blessed at the clinic to have like amazing teams, generally speaking. And that's another thing that I've seen over the course of my lifetime is people who weren't nursing is everything, but it takes everything, SPD or CPD. It takes people who replace the tanks of CO2. It takes all the things like electrical engineering, takes anesthesia, ARAS, the enhanced recovery after surgery is like amazing.
The number of people involved with getting a patient safely through surgery is not small. And knowing their names, knowing who they are, understanding their role, being grateful. The number of people who's like, no one's ever said thanks before. I'm like, how is that possible? And I'm so lucky. That's why I love where I work. That's why I'm still there at the teams that I work with. And it's not just my one person. It's like, it's the whole crew of people that I work with. They just want to do good work.
They're so motivated by providing excellent patient care. And I feel very, very lucky in the previous job that I had and this job that we've been blessed in that regard. And then in terms of like, just generally speaking, like the instrumentation, the knowledge, the cultures, I think it's always improving. Although there's still entities that I just laugh about. One of the residents told me about the surgeon who actually subsequently has retired, but she called him, she's like, oh, we love him, but we call him the always never surgeon. And I was like, what do you mean? And he was like, I guess he would just say in the first case, he'd be like, I always do it this way. And then you do his move, the next case, and he would be like, I never do it that way. It was so confusing. Trainees had no idea. So like, we all know the always never surgeons, and they're so confusing to everybody. Nobody knows, and nobody can pull it, and nobody has their cards because it's like completely different story, the next case, and everyone's confused. And then you just have to know that sometimes you just have to push back and be like, we never do it this way. And then like laughter and whatever. But if you don't know that, then it's very intimidating to the nurses who are new, but you always are going to get assigned the new person because of the yelling. You know what I mean? So it's like you can see this happening because staff are human.
Yeah, they want to be treated well. But I think the other thing that we go back to complications, though, this is a big part of mitigation of complications is creating that team feeling. But on the other side of the coin is when you have that team that cares when these complications happen, like you have to remember that other members of the team feel very responsible for that complication too. And I had to learn like so self-focused or self-centered when I had a complication early on. And it wasn't until a couple of days later when I was back in the OR that all the nurses and techs were like, oh my God, how do they do it? I'm like, oh yeah, well, it was our case. I mean, obviously I'm the surgeon, I feel most responsible, but like they were upset too. They were worried too. They felt responsible. Like, could they have done something differently? Could they have helped out more or whatever it was? Like, and that's where I think thinking about the work that we do as teamwork, as thinking in terms of systems, right? The Institute of Medicine stuff, the failure is mostly systems level stuff, not just individual. And remembering that when we have complications and they're tough, that there are oftentimes other people involved that we don't always think about that also suffer in some ways, that also are, the second victim in being involved. A lot of the surgical staff feel very responsible when cases don't go well. And so having that ability to go back and like, hey guys, how's everybody doing? They did fine. Thanks so much for helping and couldn't have gotten through it without you. Those kinds of things that I think I've had to kind of remind myself to do. Luckily, when those things happen infrequently, but it doesn't even have to be an actual complication. It could be a near miss or a case just didn't go well. We got through it, it's fine, and patient's going to do well, but it just wasn't smooth or fun. But making sure everybody knows that they're trying, that they care. And man, that's caring is just like these days, to me, it's gold. There's nothing more important to me than just finding somebody who cares.
Oh yeah, for sure. I think that's the thing that bothers people too, is just if you don't seem to care about the team or the patient, then people don't want to be a part of that situation. I mean, and I think that's one of the things about mitigating complications is also trying to avoid burnout. And that's also a systems level issue, like in terms of staffing for the labor suite or staffing of the OR or whatever it is, like the residents, just making sure that they are not being overscheduled or are able to recharge or what have you. And you alluded to the travelers before. It got really, really bad for a while there. I mean, I don't think the complication rate ticked up at all, but like the morale was really down because all the people who stuck around were getting paid less and had to do more call than the travelers. The travelers were so expensive, they'd get sent home. They didn't have to take call. And then they were trading tips in the OR. I mean,
that's what you get for being a good citizen, right? Is like lower pay and more call. Yeah, that fair and just culture thing you referenced is a huge part of it. But I think it always goes back to culture for me. But I guess my maturity arc, and I'm obviously still on the upward slope of that, trying to find more maturity, but is changing how I deal with complications from making it about myself. I have to own all of it. I can do both things. I can take more responsibility and take more ownership without spending as much time beating myself up. And I do that by caring more about the people on my team and caring more about the people that are around me to help build them up, to support them where I would have loved to have had that or where I've gotten that help in the past. And to me, that's as therapeutic as anything, is taking that grief and taking those tough moments of complications and turning that into something positive and building up the people around you so they can come back the next day too and get back in the OR with you, or get back on that team with you to try to find success again, because that's a tough thing to do when you've had a negative outcome, when you've had a suboptimal outcome, is to show up the next day and try to do as good a job. I mean, that's the thing. Docs who have complications are at more risk of having another complication, right? And that's the whole burnout cycle, right? The more upset you are, the worse it gets, the more upset you are, and then around and around and around, and how teaching folks how to deal with it. And it's not about not caring. If you don't care and you're a sociopath, you probably shouldn't be a surgeon. But learning how to care and take that caring into action and doing something to care for the people around you, minimize the chance of not having it again the next time. Those kinds of things are sort of my therapeutic approach, in a sense, to dealing with the bad outcomes. Go, okay, feel bad, you get a day, and then you go and turn that into something good, and that'll be the thing that allows you to sleep the next night.
I agree with you 100%. And then also just being prepared and just knowing I might need the flow seal. Hey, I'm going to need the laparoscopic clips. Hey, can you just have the suture in the room? Getting there early, making sure that they're prepped. If it's a case that you don't do that frequently, do it first when you have the team. I mean, I used to joke, like, after 3 or 5 p.m., you could get stuck with the Z team. Like, not just the A team or the B team. You could get the Z team. Like, you could be in 0 Kelvin situation where there's no molecules moving and it's bad. Like, do the hard case first.
Always do the hardest case first. And my day has to get easier or it's not going to be a good day. Friday afternoon, let's add on that stage 4 endo at like 3 o'clock. Like, no one else is there to help you. Everybody else is home for the weekend because they're smarter than you. They've already left for the day. Don't do it. That's the other thing is, as you get further along, you start to, I don't want to say see the future, but you start to recognize we're heading towards the cliff. You know, when you're fresh out or when you're training, you realize you're over the cliff when you're like in the air, like off the edge. As you get further along, you start to go, okay, this train is heading in the direction of the cliff. I need to know that I have enough time to stop. And then the most important thing you can do is just stop. Don't start the train towards the cliff, right? Like, don't take that patient back who's going to have an insane surgical experience, right? And so recognizing there's all the possible things over time and building up this sort of like gestalt of, I just got a bad feeling about this case. Trust that gut. You read Blink, right? Like, just like something's off about this. Not exactly sure what that means, but I'm going to use that uncertainty, that unease, that queasiness to then go back and use my head to figure out, make sure all my boxes are checked. Something's not right. I need to go back and make sure every single thing is checked. I'm going to be the first one in the OR, making sure I have my tools, like you said. I'm going to do a little extra. We're going to check the OR, see who's around, or whatever it is that you have to do to like prepare, because this is going to be tough.
There was something that like I was watching on social media, and this guy posted, that's Ron Barbosa. He posted something.
The suture guy, right?
Yeah, the suture guy. But he posted like this screenshot of this super old text from like 1900s, and it was like complicated, or maybe it was even earlier, maybe it was 1700. Anyway, it was like some old text, and it was like, complications always come in threes. They do come in threes and fives. Like, you gotta just be prepared for the next one coming around. And if you can break that cycle and just have one complication, that's great. But like, usually it does come in a trio. So I always like
on edge.
prepare. Yeah, I prepared for it to come around. And just know that that's like everybody is like ready for it. And the other thing to know is you can say quit. Like, if you had like a gnarly case that takes 8 hours instead of like the 2 hours that you thought, it's okay to cancel the other cases as long as it's not like some emergency case, because you're not doing anybody any favors.
If you were that patient or their family, you'd be like, I don't want that surgeon operating on me right now. They're just not there yet. No, that's great advice. If you're not in a place where you can do this case well, like, don't do it. Obviously, like you said, unless it's urgent or emergent, but like, don't put yourself or others in that situation. It's just not worth it.
The other thing I will say is that, I remember coming out and booking like 2 sacral colpopexies in one day. And my partner was like, I wouldn't do that if I were you, not here. And I was like, I couldn't even do the second one, or like I was operating all night or whatever. It was like not a good move. And I like to caution people, because I think everybody does this when they first come out. We're all like optimists. And I like to be a realist. Like, my cases take X amount of time. There's Y minutes turnover. I mean, we track that very closely. It's between 35 and 40 minutes. I acknowledge I walk out of the room earlier than everybody else. So
my turnover time's an hour and a half because I'm having coffee while they're, getting the patient moved and all that stuff.
Right. Yeah, exactly. So then, but knowing what everything is going to be like, I kind of know how the day is going to go now. And then also, the other thing I will say, and this is not a complication thing, but just a managing your life thing, is do not tell your family you're going to be home for dinner and you have like 3 debulks on your schedule, your oncologist or whatever. My friends were doing this. It's like such a common surgeon thing to...
Like you said, under promise, over deliver. Like, hey, it's going to be a long day. Don't count on me for dinner. I would love to go to this game tonight. I probably won't make it. Then you show up and it's like, oh my God, this is great. As opposed to like, oh, why aren't they there? They don't care. Yes, I think that's great advice.
I mean, honestly, you're just better off, because my friends did this and literally they had to go to couples counseling, several of them. And then, the spouse can handle it, but when they start having to cover for you at dinner and the baseball games that you didn't make because you're on call or whatever, it feels like lying. And then they don't want to cover for you anymore.
When you don't want to be rushing out of work either, right? Like, when you're there at work, you got to be present. You got to give the patients time, right? That's another great way to avoid complications, is set yourself up for success. Give yourself the time to do the case. If you have too much on your schedule, then you're going to be pushing through, and that's another great way to get yourself into trouble and do things you wouldn't do otherwise. And that's the hard part, is when it is 4 or 5 o'clock and you're just getting started on that last case because the first case went long. And are we going to be doing the exact same case we did at 7:30 a.m.? You should be. You should be able to be in that mindset where you can do this, the same case at the same amount of energy. It's not always possible, but thinking about, would you want you operating on you right now? And if the answer is no, you probably should bail a little bit. And just, it's hard because we have ego and we have pressure and we have people who will be disappointed that the case got canceled, the family and the patient, because it's a big part of it too. But the patients, what they do to get ready for surgery, taking off work and mom comes in town so they can stay with them or whatever it is, or the husband's taking a day off work, and then they sit around all day MPO, childcare, and then you cancel the surgery. Oh man, like, that's brutal and it kills you. But like, that disappointment, I can promise you, is better than the disappointment of a surgical complication. And that's what you have to, like, not that you're definitely going to have one, but like, you just have to be okay with disappointing people sometimes when it's like for the benefit of the people involved. And that's a hard pill to swallow, I think, for a lot of us, because we don't want to disappoint people. But sometimes you have to try to be, that's why pilots have limits on their sleep, right? You didn't sleep enough, like, flight gets canceled. Well, but the pilot's right there. Yeah, but they didn't sleep enough. And like, we're just cutting it off. We're not going to give them a choice. Like, why don't surgeons have that? Like, if you don't get enough sleep, like, why doesn't the hospital, like Delta or American Airlines, they just say this guy's not allowed to fly? She's off shift because she didn't sleep enough last night. Surgeons don't get that.
I think managing oneself is a big thing you have to learn. And all of this stuff that we're talking about is part and parcel of that, like impulse control, the yelling, the like time management, the scheduling, Like, you have to look at your schedule because no one else will manage this but you. So I have a surgical scheduler who does things, but I look at the schedule a week or two in advance and I'm like, can you switch the laparoscopic sacrocolpopexy to the first round case? Because you know what? When they have to prepare that. They have to prepare it for a 7:30 start. It's not on me for the turnover, right? Like, they can just do the vaginal case, which is a much easier set to do in between.
Do the robot case first.
Yeah, do the robot case first, whatever, the hard case first, because all that stuff has to be all set for 7:30 start. But I think it's also just bad form to blame your team, like your surgical scheduler for look at what they do to me.
It drives me insane when people do that. I'm like, do you know how lucky we are that anybody is helping you at all? Like, at all. Like, your job is to say thank you. Certainly you can talk to folks and say, hey, can you try to do this to perform a little better? But you own your schedule. Look ahead, figure it out.
You're in charge of you. And so if it's not to your liking or you don't have enough time or you need to move up a case or whatever, it behooves you to look at it in enough time where it can be changed. And sometimes I'm like, okay, this is not going to be a 3-hour case. It's going to be a 2-hour case. Can you bring up the schedule? And then don't complain about your day not going the way it should if you didn't look at the cases 2 days before, because the day before you can change the schedule. You have to just do it before 1:30 or 2 o'clock.
When they call the patients, yeah.
Yeah, that's it. So, I think that's some of the hidden curriculum. Well, but it's part of the thing about managing your schedule appropriately, and nobody likes a culture of blame. And when you start blaming your surgical scheduler, the trainees are listening and they're like, oh, wow.
That's how you get things done. You yell at people or you make them feel small, or I guess that's how this works. You're teaching them that. You're 100% right. I think I've told the story before, but I remember I was a resident going up to the post-op floor, chatting with nurses, and they were showing me baby pictures and stuff. And then one of my co-residents came up and she went and opened up a chart and had to write up, this is back with paper charts and paper orders. That's how old I am. And she went away. I was like, what was that? They go, oh, well, she had to, we don't take verbal orders. I'm like, what are you talking about? You take my verbal orders all the time. They go, yeah, but we like you. That alone, I was like, oh my gosh, that was my little light bulb moment. Because I'm nice to them, they'll do things that make my life easier, but that allows me to focus, to not have to leave L&D to come write that order or not have to walk across the hospital. Now I can spend more time focusing on other patient care things. When you're being mean to people, they don't want to help you. They don't want to help you. And the more that we treat people well, the more they speak up, the more they help each other, the patients are going to do better, because we're now all worried about one person, the patient. If you're worried about what the surgeon's going to say, you're worried about the wrong person. And that's something that I've stressed again and again. With when my residents call me 2 a.m, it's, hey, what's up? I used to get screamed at as a resident, calling on attending at 2 a.m. They didn't like my presentation, just yelled at. I didn't want to talk. I was frightened to call them back. What if there was something I had to tell them, but I was too scared they're going to yell at me again? For me, I want to know. I want to know that thing that they were going to call me about. So how you respond to people, how you treat people, a huge way to minimize complications is just be nice. So people will call you and tell you things, and be my patients, call me soon, right afterwards, encourage them. Call me when things are small. I can fix the UTI. Pilo is much harder, right? Or a small pelvic infections, antibiotics, leaving it alone for days as an abscess, that's much harder. So let me know anything. Let's treat little things when they're little. But that's all culture. It's all how you treat people.
I agree. I think people get caught up in all these technical points of maybe it's using the uterine manipulator more when you're doing a hyst or whatever. But yes, and all of those things are really important. And that's, I think, a really good for trainees especially, but even attendings to watch surgical videos nowadays with IAPS and Surgery U. I almost feel like it's such an amazing supplement to textbooks, and there's up to date and these really concise, great ways to learn surgery. Yes, all of that is important, but all these other things are super important as well.
What's the saying? Culture eats strategy for breakfast.
Yeah.
You can have everything planned out perfectly. Everything's set up in the room. You can have everything you're going to do for that case. If you're treating people poorly and you're yelling or whatever, doesn't matter what plan you had. That day is just not going to go all that well. And the opposite is true. You can do everything, you can be surprised by something, but when the team steps in and figures out how to solve the problem with you, culture got you through that more than anything else, or as part of it at least. I think, obviously you got to know your anatomy and know how to do surgery and be prepared. But sometimes this job surprises you, and having a team who's willing to jump in and help out without having to be told could be the difference between something we figure out and something we miss.
Couldn't agree more.
We could go all day. I think that's a nice point, though. I think I came in here thinking about like complications and all the second victim stuff, which we've talked about on this show before. I like that you brought it there. I like that that's what we talked about is ultimately, and I agree 100% with what you said, the way to mitigate complications and the way to do your best to minimize that they happen. Because yes, like if you're not getting complications, you're not operating in general. It doesn't mean you should have a lot of them. Getting as many people to help out as you can in a case, to buy into what you're doing, to pay attention, having as many eyes and ears in tune to what's going on to help this thing get through more safely can dramatically reduce your risks. And that was the other study. They had 2 teams they evaluated. One was a very well-run team and one was not as well-run team. And which one had more reported adverse events, the well-run team or the poorly run team? The answer is the well-run team, because they were more comfortable, they had more psychological safety to bring up problems so they could find near misses and report them and not actually allow those bad things to happen. They were more comfortable. They created that culture of safety where they could speak up and say, here's the thing that I was worried about that almost happened. I screwed up. Well, let's create a system that makes my screw up not actually result in a bad outcome. And those teams run better, even though the ones that are quiet and don't have as many complications aren't as loud. The reason is because they're just not talking about the things that are there all the time. So I like that we got to talk about that today. It's a hugely important thing to me. And I like that my friend Amy also thinks the same thing as me.
Yeah. I mean, again, and I know I said this multiple times, but just really doing a deep dive and a hard look and analyze where you went wrong, I went wrong, how to make it better, solicit feedback. I think those are all, talk through it.
Surround yourself by supportive people. Find your allies, find your mentors, find your support network. If it's not in your department, go outside the department. Find people who will make your day better, who will build you up. Bucket fillers. Did you read your kids that book?
I've never heard of that book. But the other thing is they don't also have to be a bucket filler all the time. They can give you the hard talk and be like, this is where you went wrong. And that's fine too. You just have to be in a safe space where people feel like they can tell you.
The bucket fillers are the people that fill you up. Even it doesn't mean it's always like BS. They're just people who just take and take and take from you and leave you empty. But yeah, no, the people who've been honest with me are the ones who have told me the things that I needed to hear, not the things that I wanted to hear. Are the ones who I'm truly grateful for, because those are the ones who, if I've had success in this career, if I've had success in what I've done, it's in no small part because of the people who just sat me down, pulled me aside, bought me a cup of coffee, and told me exactly what I needed to hear. And not everybody's as receptive to that, but I think it's important to be as good at getting feedback as you are at giving it, and always be open to feedback. And as residents, my residents tell me things, I'll listen. I'm not perfect as an attending. I can teach better, be more patient, whatever it is. I want to get better. But yeah, a lot of self-reflection, a lot of humility in this job goes a long way.
I think there's a reason why the ACGME survey at the end of the year specifically asks about a culture of retaliation. That's a big citation.
As it should be, because we have to have, it's got to be a space to learn. Learning is hard enough as it is. We don't need to, being a resident, being a doctor is a hard enough job. We don't need to make it worse by psychologically unsafe spaces. All right, shall we wrap it up?
Sounds good.
Awesome. Always a pleasure. Good seeing you. And we'll do this again soon. And to all of our listeners out there, thank you for joining us for another episode of BackTable OBGYN.
Thank you so much for listening. If you haven't already, make sure to follow the podcast, rate it 5 stars, and share with a friend. If you have any questions or comments, direct message us at _BackTable OBGYN on Instagram, Twitter, or LinkedIn. BackTable OBGYN is hosted by myself, Mark Hoffman,
and Amy Park.
Our audio team is led by Kieran Gannon, with support from
Josh McWhirter,
Aaron Bowles, Nick Shellcross,
Josh Spencer.
Design and digital marketing led by Brian Schmitz, with support from
Taylor's Version Hess and Yvonne Orgodzinsky.
Show notes and social media by Emma Landonwich and Lindsay Beecham.
Administrative support provided by Jamila Kennebrew.
Music written and performed by Scott Baby Daddy Hoffman.
Thanks for listening, and we'll see you again next time. The views and opinions expressed by the hosts and guests on BackTable OBGYN are their own, and do not reflect the views or positions of their employers or any entities they represent.